How many people have done thyroid surgeries? How about parotid? Okay. So doing the thyroid and parotid surgeries, the anatomy is very, very important. So if you have to familiar with the anatomy of the muscles and the nerves. So during the high-risk surgical procedures, neurophysiological monitoring, the facial nerve and vagus nerve are utilized for protection of the patient motor function. So we are doing monitoring for the protection of the motor function. So even EMG is used for last 20 years and more, but still being considered as a new. It's not new anymore. And the purpose of doing the EMG monitoring for these cases is to get a real-time feedback and without averaging to the surgeon. So the nerves which are most monitoring cranial nerve in the surgical are 8th cranial nerve and 7th cranial nerve. And morbidity trauma to these nerves is significant and obvious, such as unilateral facial paralysis, which have effect on your eye closing, dryness of the eyes. It can lead to corneal ulceration and blindness. So taste function, swallowing, all those function. So parotid. So anatomy of the parotid gland, again, I thought it just follow it with Justin because he already went through that facial nerve monitoring. So parotid gland is the largest salivary gland in the human body. It's a salivary gland. It's the largest salivary gland, and the average weight is about 25 milligram. It is located. It's an irregular. It's a lobulated gland, and it is below the external acoustic meatus and above masseter, between mandible and sternocleidomastoid muscle. So it's right. In simple English, it's on your face. So function is secrete saliva via parotid duct into the oral cavity. So it has a small duct which opens into the oral cavity behind your lower molars, and it secretes saliva in the oral cavity. The facial nerve travels to the parotid gland and divide into multiple branches before supplying the muscle of the facial expression. So facial nerve is responsible for the muscle of facial expression, and the facial nerve enters the parotid gland and it splits into all 5-6 branches. So I don't know if you have done any dissection or cadaver. So parotid gland is one of the toughest gland to dissect. So you cannot just go and split. So if you see that surgery, so they're just picking one small pieces. So compared to the other muscles, it's a very, very thick and very tough gland, and all the nerves are going through that. So it's very difficult to dissect. So most tumor of the parotid glands are benign. However, most 80% of salivary gland tumors begin in parotid glands. And the surgical incision of parotid glands, which is parotidectomy, is often performed as part of the treatment. So that's a surgical treatment. And facial nerve is jeopardy because they are going through that. So you need to understand the history of the muscle disorder, and aesthetic requirement for the surgery, set up of the patient with stimulation and recording parameters, and record the baseline before you do the surgery, and document and report the data during the surgery. And the whole thing is to done so during the surgical procedure for parotid, we want to preserve the function of the parotid gland, all the 5 branches. And so in general, the parotid gland may become infected by infection agent and pass through the bloodstream. The typical diseases you see clinically are mumps, acute communicable viral disease, and it's a very painful. You have swollen. You see the patient with a swollen face. Parotiditis is inflammation and swelling of the gland, and cellulite and calculus is the duct blocked by the calcified deposit. So those are the 3 common diseases you see in the patient beside the tumors. So again, understanding the anatomy of the facial nerve is important. It has the mnemonic I'm using: tall zebra bit my cousin. So you have temporal branch, zygomatic branch, buccal branch, mandibular branch, and cervical branch. So the temporal branch, sometimes you have 1 or 2 temporal branches. It supplies your frontalis muscle. Zygomatic branch, so the facial nerve is coming and it's going through that parotid gland, and you see it has outlined layer which is very, very thick. So it goes through that and supply the oculi, oris, orbiculus oculi. The 3rd branch, the buccal branch, it supplies your orbiculus oris and sometimes nasalis. And the mandibular branch supply mentalis muscle on the chin, and the cervical branch supply your platysma muscle. Platysma muscle is a very, very thin muscle. It's the only muscle in the body which has no bony attachment. It starts from under the mandible and it's attached to your above the clavicle. So you can stretch. I can move that very easily. But in order to monitor from the flapellatus muscle or cervical branch, you have to make sure you are putting the electrode parallel to the skin. You're not going deep in because you will be under different muscles. All the branches are important, so if you have this muscle paralyzed, so you will not be able to move the flapellatus muscle. Again, so you have parotid gland. This is the parotid gland. It has the parotid ducts. It's opening in the mouth. And for reference, zygomatic arch with the bone. And you have sternocleidomastoid muscle coming here. Masseter muscles is under the parotid gland, and buccinator is behind that. So to start with, if I'm doing parotid surgery, what I do is ask the surgeon, can we stimulate on the skin? So we can stimulate on the surface, monopolar handheld stimulator, and mark with the marker. And when they're doing dissection, so it's much getting a reference point where are the. So you can stimulate the skin and you can mark all the branches. You have to have a higher stimulation though. So again, same thing. The surgery, the parotidectomy, is a well-established surgical procedure and is performed mostly almost by the ENT and head and neck surgeon. And peripheral branch of facial nerves should be monitored, all the branches. So you cannot just do oculi and oris and say everything because all the branches are at risk. The damage to the nerve can be caused by sectioning, stretching, compression of the nerve. It can be caused by thermal or electrical injuries, or ischemia, and it can lead to temporary and permanent loss. So this is one of the patients we did. It had a large parotid. You can see swelling. So we put the electrode on mentalis. Oculi have oris and platysma. This is intraoperative, so we have exposed area. We're doing EMG recording. There's a different machine. So this is another patient. So this patient was, you can see this is before the surgery. So he has this big tumor which was oozing out. It has a secretion coming out. And this was 107-year-old. So when the surgeon brought it, I said, okay, why, like he had that tumor for a very, very long time. I said, why it took him so long? He said he was afraid of surgery and he didn't want to. And so why he came today, he said he's brought by his kids. But his kids were 95-year-old, one was 95. I said, okay, those are the kids. Okay, so they forced him, this kid, 95-year-old kids forced him to get surgery. So what we did is because all the muscles, the skin was destroyed, so the plastic surgeon, he took the whole skin out, and you can see the clavicle here, so that was removed. And this is the tumor out, so the tumor was taken out, and the skin was stretched back and was really sutured to the patient. So, sound. So that's the typical EMG sound. So you cannot see any branches, you cannot see any nerve. You have to have a loud EMG. So what Dr. Bazar was saying that in the past, like when we were doing EMG, so it was always a sound feedback to the surgeon, and sometimes they say, okay, it's too loud, just turn it off and tell me when you have. But the feedback, so when you have a continuous or regular activity, you cannot just say, okay, activity, you cannot shout. So the audio feedback is very, very good. So, and even you are not monitoring and you are focusing, you're talking to somebody, or you switch your eyes not on the computer, you can still hear that. So you have two feedback. So if the patient has activity there. So going to thyroid surgeries. So again, the thyroid surgery is another very common surgical procedure and has the vagus nerve is at risk. The branches of the vagus nerve at risk are recurrent laryngeal nerve or inferior laryngeal or superior laryngeal nerve. The superior laryngeal and the recurrent laryngeal are both at risk, but 90%, 95% people, they don't even monitor superior laryngeal nerve. You can monitor recurrent laryngeal nerve from vocal cord, and patient can still wake up with a hoarseness of voice because the superior laryngeal nerve is damaged. So the current guidelines recommend definite visual identification of recurrent laryngeal nerve and superior laryngeal nerve during thyroid surgery, being this as the most reliable method of reducing the rate of the injury. There was a paper published by Herman et al., and they compared two historical cohorts with the 26,000 patients undergoing thyroidectomy for being benign disease, and they divided the patient group into 79 to 1980 and one from 91 to 98. And it was a routine procedure before that visual identification. So when in that paper they say when the nerve is visually identified, the injury rate is much lower, as 0.4% than not looking at visually at 0.1%. So with neuromonitoring, with the triggering EMG, we can help that, and we can lower that, because even we can tell we can tell about the nerve even before even reaching to the nerve. So the understanding of the anatomy of vagus nerve branches is detailed before performing IM for any type of these cases. So you have to make sure you know the 3D anatomy, not one direction anatomy. And you cannot just walk in and say, okay, this is EMG, because you need to know like what are they going to do, what is the next step, and what is the structure behind that. So it is a 2 inches long, and the thyroid gland is a butterfly-shaped organ located in the base of your neck. It releases hormones which control metabolism and regulate water function. It's about 2 inches long, and thyroid has 2 lobes, left lobe and right lobe, and they are attached to each other. The function, it regulates breathing, heart rate, central nervous system, peripheral nervous system, body weight, muscle strength, menstrual cycle, body temperature, and cholesterol levels. So it has multiple implications if there's a damage to that. The thyroid gland uses iodine in the diet to make 2 main hormones, T3, T4, which is triiodine, hydrothioronine, and thyroxine, or tetraiodine. That's one is tri and one tetra. And iodine is deficient in most hilly areas. So if you're living in a mountain area or high altitude area, so you have to make sure you are supplementing iodine in your diet. So T3, T3 hormones, they are maintained by two glands in the brain, hypothalamus and pituitary. So if there's a change in hypothalamus and pituitary, that will affect indirectly your thyroid hormone. The hypothalamus produces thyroid stimulating hormone and thyroid stimulating hormone releasing hormone, TRH, and that signals the pituitary to tell the thyroid gland to produce more or less T3 or T4 by either increasing or decreasing the release of hormone called thyroid stimulating hormone. So this is a typo, should be just thyroid releasing hormone is stimulating the brain, and it stimulates the thyroid to stimulate T3 more and T3 less. So when T3, T4 are less, the thyroid hormones are less and low in the blood, the pituitary gland releases more thyroid stimulating to produce more thyroid. So if the T3 is less and the thyroid stimulating hormone is stimulated more in the brain, and if cannot function that, the thyroid can get bigger and bigger, and then you see those goiter and all this. And if the same thing, if T3 is opposite, if is high, the pituitary gland releases less thyroid stimulating hormone to release less thyroid stimulating. Why they're important, why I'm talking about that, because when you're talking to the patient or you're going to the surgery or you have, so you need to know the implications. So same thing as spine, when you go for spine monitoring, you know that patient will lose SSCP, he's going to lose stereognosis, weight discrimination, all those functions, proprioception, and if you lose motor function, you have change in MEP. So same thing with thyroid. So if you have a change in thyroid or you lose the nerve or function of thyroid, what will be implication on the body? So patient with hyperthyroidism, they have more anxiety, irritability, nervousness, sweating, hand trembling, hair loss, hypothyroidism, trouble sleeping, tiredness, fatigue, dry skin, depression, sensitivity. The problem is, like, when you go through all the list, half of you, I think you're thinking, right now you're thinking that I have a hyperthyroidism, and the other half is thinking that I have hypothyroidism. Don't take it personally. Take home message. So 85% tumors are papillary mixed tumor, 3% of thyroid cancer, and 1% are anaplastic, and 10%, I missed that, 10% are follicular tumors. So those are the 4 different type of main tumor. So the vagus nerve is one of the longer nerve. Vagus means wandering. Start in the brainstem. It goes through the jugular foramen, along with 9 and 11 and jugular vein. It travels down the neck, chest, abdomen, and pelvis. So it's going all the way, and it keeps supplying all the muscles. So voice production is divided. Vocal cords is responsible for voice, and they have 3 major categories for the production. One is power source, vibratory source, and resonator. So the difference between one is the power source is the breath that supports your sound. Vibratory is the vibration of the true vocal cords, and resonators is to give the richness and tone that makes the voice more musical. So I have something missing here. Thyroidectomy is defined as a surgical procedure performed partially or completely. So you have taking a half gland out, you have partial thyroidectomy, or hemithyroidectomy, or taking full thyroid gland out, total thyroidectomy. So the risk of having in thyroid surgery, you have patient can have vocal cord paralysis and can have voice changes, aspiration, can aspirate more, have pneumonia, aspirated pneumonia, can suffer from airway obstruction, and may have to go for tracheostomy dependence for the rest of his life. So in this picture, you can say unilateral, one-sided vocal loss. So the patient cannot close that one. Only one vocal cord is moving, so that talk. On the other side, both are moving. So recurrent laryngeal nerve supplies motor innervation to all the intrinsic laryngeal muscle except for cricothyroid muscle. The cricothyroid muscle is supplied by the superior laryngeal nerve. So you have the left and right. So the right laryngeal nerve comes down, and it loops around this subclavian artery, and it supplies the left one takes a longer. It loops under the arch of aorta, and then it supplies this. So all the time, that's one of the CNM questions. Left laryngeal nerve is at higher risk of having damage than the right one because it is longer, so it has more risk of having stretch. So we have superior laryngeal nerve, which can be recorded by cricothyroid muscles, which is between thyroid and cricoid cartilage, and then vocal cord muscles. So we can record the superior recurrent laryngeal nerve. The superior laryngeal nerve, you cannot put the electrode there. Recurrent laryngeal nerve, we can put the electrode there. So for recurrent laryngeal nerve, we can use either use endotracheal tube from different manufacturer, which has 2 pair of electrode on left side and right side, and this exposed area is all insulated except for this area above the bulb, and that attached to the vocal cord. And this is a picture from the laryngoscope while they're putting, or you can get a sticker which you can wrap around, and you can have a connector, different type of connectors which you can connect. This is a bipolar recording, so you can differentiate between left side and right side. This has a bipolar 2-channel, but you cannot differentiate left and side. It's more sensitive, but less specific. So when you say the guidelines say that visual identification of thyroid gland is important, so that's important, but depending on thyroid, okay? So how do you do that? And also, like, I do MEP too, so you can do continuous MEP and patient doesn't move in these when. So if you have a changes more proximal, so because when you do triggered EMG in thyroid or recurrent or superior, you're just giving information at the time of stimulation and more distal, but you have no idea. So patient like this, you have a risk of damage more proximal to the site of explosion. So so in order to monitor the pathway more proximally, you can run continuously MEP during the surgery. So one of the patients have draped on, so you can see a bulge, make an incision. So the surgeon is exposing. I don't know if, so he's taking the thyroid, he is holding the thyroid gland in hand, and then tumors. So this is the thyroid, so I asked him to hold him, and he's pointing. The nerve is, I don't know if you can. I asked him to find the nerve so I can take a picture of the nerve. So it's a big tumor. So there's a different patient. Another patient exposed, the tumor is out. So finding the nerve having a damage on these cases is much higher than the small tumors. Another patient, so you can see the tumor is here, so need to find superior laryngeal and recurrent. The superior laryngeal, what I was saying, you have to ask the surgeon to put the electrode once you open. When you take out when you expose the thyroid gland, they can move the gland on one side and have to put the electrode, the one Justin was saying, those are the ideal electrode, or you have a paired electrode, you can put intraoperatively by the surgeon in the cricothyroid muscle. And once you are done stimulation, they move to the other side, they take the electrode out, recap, and then go to the other side and have to put it again. We cannot do without, because in order to reach the muscle, you have to move the thyroid, you have to expose the thyroid gland. So we can do, what we do is recurrent laryngeal nerve, but by stimulating the endotracheal tube and then giving the electrode, sterile electrode to the surgeon for those. So this is the recurrent laryngeal nerve. So I have tumor exposed. This is a post-op, and we are closing here. So when you're looking at Gray's Gray's Anatomy or any other anatomy book, the nerves look very, very nice. You can, like any blind person can tell, not blind, but any person can tell the nerve. But when you are operating, everything is red. Tuck, 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 tuck. It's very easy, monitor. But when you have exposed areas, so you have nerves, veins, everything is there. So you have no idea. Everything is red, all bloody. So you need to find it and like squish. So that's why I triggered EMG. And now we have, I think we have recording, going back to recording. Okay, so selection of appropriate modality for given procedure, any procedure. So you have to make sure you are giving the maximum. So we cannot do single modality. We have to have a multimodality. So even a triggered EMG, so monitoring and mapping. So monitoring is like you are continuously stimulation. There are stimulators you can put on the thyroid recurrent laryngeal nerve and stimulate nonstop. You don't have to ask the surgeon. And then you have mapping, which is surgeon is stimulating. So you have to confirm the integrity of both stimulation and recording setup before you start surgery. So the stimulator, so you can tab on the gland and see, okay, or facial nerve, if the recording is working, the sound is good. Test the stimulator before you start stimulating the patient. Obtaining a baseline of EMG responses from the neck, increasing the stimulation until get response. If you're doing direct nerve stimulation, you can go to 1 milliampere or 2 milliampere. And utilize the continuous direct nerve stimulation, and also after post-resection, confirming the integrity of the nerve is still intact. Sometimes the threshold, if the baseline is 0.2 and yet the post-op is 1 milliampere, the patient may have some weakness and definite damage post-operatively. So again, be conscious about active versus passive monitoring. The active monitoring is you are doing continuous monitoring, either doing MEP continuously during the surgery, or doing a triggered EMG by a hook clip electrode versus passive monitoring. Then when you have EMG or train activity and you say, okay, let's stimulate and test the nerve is there or no. So proof system is working before incision, check recording electrode, confirm current flow, get baseline, final stimulation after the surgery. Typical EMG setup, low cut 10 Hertz, high cut 5000. For spontaneous, you keep the sweep very high, minimum 300 Hertz, 500, so 300 millisecond, 500 is good, but many times people you cannot like so squish, because you have 300 millisecond per division, you have 3-second window. So if something you miss, it will still be there for 3 seconds. But if you have 10 millisecond per division, the response will be so quick you will not be able to see that. For triggered EMG, you can keep at 1 millisecond per division or 1.5 millisecond. Montage for parotid glands, monitor all the branches because all the branches are at risk. So not one. Temporal branch from frontalis muscle, zygomatic from oculi, buccal from oris, mandibular from mentalis, cervical from platysma. And for thyroid gland, make sure but you have to talk to the surgeon beforehand and tell them, okay, we can, unless he said I don't want superior laryngeal nerve, but there are a lot of paper published on superior laryngeal nerve paralysis and effect on the speech. So again, we're looking for MEPs or EMG, no muscle relaxant, easy, trainer 4. So the goal of monitoring and thyroid and parotid gland is identification of the nerve, tracing the nerve through the tumors, protecting the nerve while they are doing resection and checking the integrity of the nerve post-op. So we have to be careful about current shunting, because current shunting you're stimulating, so you have to have dry area. Bipolar stimulation, bipolar concentric stimulators are ideal for doing the concentric stimulation to minimize. But for identification, you have to use a monopolar stimulation. Bipolar stimulator, you can have a side-by-side or bipolar concentric. So concentric is you have the cathode in the middle, negative, and anode is surrounded, so it minimizes the current stimulate. So it has a very high specificity but very low sensitivity. Monopolar, they have a high sensitivity but low specificity. So to find the nerve, it's ideal to find the nerve by monopolar stimulation. But once you find the nerve, you want to track the nerve, you can switch to the bipolar stimulator. And for continuous, there are different stimulator from different companies. So this is one from the German company. So you can clamp on that. Medtronic has this. IONM has that. Go to the data. So if you are monitoring all the branches, so you'll have responses. So you're doing trigger EMG. So one of the cases from so you have responses from Autosoft. Again, trigger EMG. So this is 8-channel EMG machine. So you had a continuous vagal stimulation, you can do that. So because with the trigger EMG handheld stimulator, you have to do while the surgeon can do that. But in order to avoid the big tumors or big stretching, you want to make sure there's no change in threshold, there's no change in amplitude. You can put this on the exposed area and do continuous stimulation and do a continuous recording. Looking at stack of trigger EMG, looking at spontaneous and the stack at the same time. Left and right recurrent laryngeal nerves. So I have EMG. So this is normal vocal cord. So just giving a sample. So what will be its take-home message? So what will be effect on the patient? So so both vocal cords are working. So now, if the patient has a unilateral vocal cord paralysis, he will not or she will not be able to use one side. So this side is moving, but the right side is not moving, it's paralyzed. And the patient with the bilateral vocal cord paralysis, nothing is moving. That will be the outcome for the rest of the life. Okay. So for monitoring this patient, understanding the anatomy and physiology is very important. Just don't go in as a regular EMG case. Stimulation and recording parameters for troubleshooting, and understand the different diseases, pathologies, because every patient will be different, will have a different size of tumors, will have different type of surgical team involved, and patient will have different. That's it.